So, assalamu alaikum, everybody, and good afternoon. I hope everybody had a great lunch. And it's extremely delighted to be part of this inaugural conference on cardiovascular disease in women. And I'd like to thank Dr. Joyria and at the same time congratulate her and the scientific committee for an amazing achievement. So my task is really to concentrate on the impact of diabetes on women's health. So we'll be talking about the sweeter side of things. I don't have any relevant disclosures for this presentation. And my outline will be to highlight the elephant in the room that you've already heard so much about in the last 48 hours or so. And then, like everybody else, I'll explore some of the gender differences in terms of the outcomes of cardiovascular disease when diabetes is put into the mix. And then, more importantly, I think, is to try and address some of those strategies that we can really adopt that can improve heart health in women with diabetes. So suffice to say that cardiovascular disease is the leading cause of death in the world, and it has been recognized as a major barrier to sustainable human development. So much so that just a decade ago, in 2011, the United Nations actually formally recognized the NCDs, meaning non-communicable diseases, of which diabetes, cardiovascular disease, cancer, and chronic respiratory diseases is a part of, is a major concern for global health, and they put forth ambitious plans to try and curb the effects of these diseases. So here we look at the Sustainable Development Goals, and if those of you who were at the Expo, they were posted everywhere around the Expo pavilions. There are 17 of them. The third one is to have good health and well-being. You've also heard a lot about this study, the global burden of cardiovascular diseases, and therefore I'm not going to labor too much on that. But the three sort of highlights that came out of that paper was the fact that the number of cases of cardiovascular disease have actually doubled in the span from 1990 to 2019. And then the number of deaths has also steadily increased, and the trends for disability-adjusted life years and the years lost have also doubled within that time frame. In tandem with that is a not-so-silent epidemic. We've had also the rapid rise of diabetes, and the latest figures from the International Diabetes Federation tell us that we've got over 500 million people currently living with diabetes. And if you look at the map, the heat map, wherever in the continents you look, and I don't think the highlight is working, the pointer is working, you find that every continent has a projection in the northern trajectory. What's more important for us, I think, in the Middle East and MENA region, highlighted in the orange, is the fact we're going to face the second highest increase in diabetes, 87%, only second to the African continent, which is going to see more than 100% increase in the number of cases of diabetes. I've only taken one snapshot out of the IDF Atlas to show you the number of deaths in terms of the differences in the gender and age. And what we can see here is when you look at the younger age groups from 20 to 69, the death rates are almost the same. But all of a sudden, when you get to 70, there's an exponential increase in the number of deaths for women, and this is for men and women with diabetes. So what is this link between type 2 diabetes and cardiovascular disease? We know and appreciate that the cause of death in patients with type 2 diabetes, the number one cause is cardiovascular disease, much more than cancer. But breast cancer is highlighted, and simply because they've run a really fantastic campaign, and I hope we're going to be able to match that so that we can impact and reduce the risk of death in people with diabetes as well. So 2/3 of the deaths in diabetes are actually attributable to cardiovascular disease. So here, if we looked at men and women, both men and women, and you look at men and women with diabetes versus the matched controls, you find that the deaths for those people with diabetes are much higher. And in fact, diabetes increases the risk for all vascular events, including cerebrovascular events. And I know there's going to be a more detailed discussion about that by the next speaker. So indeed, diabetes does affect life expectancy. So if you look at somebody age 60 with no diabetes, and then you put diabetes in the mix, you reduce their life expectancy by about 6 years. And then when this individual has an MI or a stroke, you reduce their lifespan by another 6 years. So let's look at the differences in the outcomes then with diabetes and cardiovascular disease. What are sort of the current trends and disparities? Now, the gender differences have already been highlighted, and therefore I'm not going to labor too much on this. We know that women who succumb to heart attacks, they will have more disability in terms of heart failure than their male counterparts. We know that younger women, usually within the age of 42 to 60, are 4 times more likely to die from a bypass surgery than men in the same age group. And we know that women who have cardiovascular disease are going to have more fatalities than their male counterparts. But what's the impact then on diabetes, specifically on women? So we know that women with diabetes are 10 times more likely to have cardiovascular disease than women without diabetes. Women with diabetes have double the risk for having a heart attack than a woman that does not have diabetes. Diabetes also doubles the risk of a second heart attack in women, but somehow not in men. And the relative risk of fatal ischemic heart disease with diabetes is 50% higher in women than in men. Women with diabetes are also 4 times more likely to suffer from strokes than women without diabetes. So what are the sort of factors that might be contributing to this? I don't know whether it's showing very well towards the back of the room. There's lots of things, but what I've highlighted in the sort of red brackets is, one, the diagnosis, a delay in diagnosis seems to occur more, that's more prevalent in women with diabetes, especially when it's premenopausal, the propensity to treat. And then we look at things like responsiveness to treatment as well. And then in the middle there, I've highlighted the inflammatory response seems to be also increased in both premenopausal women, whether with or without diabetes versus their male counterparts. So the other thing that we also recognize, although the risk for heart disease and diabetes may emerge before menopause, so premenopausal, they're kind of, women are more protected, but women with diabetes lose this protection. And the other thing is that the detection and the evaluation of coronary artery disease is really difficult because of the lower sensitivity and specificity of the biomarker assays in women. So cardiovascular disease, is the leading cause of death in women globally, yet it remains understudied, underrecognized, undiagnosed, and undertreated. And why is that? Well, we've already heard a lot about the symptom complex, that it may really be confused with the menopause. Women are less likely to get high-dose statins. So I have patients with diabetes, they've had a cardiovascular event and they come to the clinic with statins, sometimes with no statins at all, because somebody has told them that, it's going to cause problems, or they're on very low dose statin, and when you suggest that you should be on a higher one, they say, oh, but don't you think that's too much for me? That's a man's dose. There's always poor clinic follow-up because women are busier taking care of things. So there's issues with medication compliance. And then I want to really touch upon the underrepresentation in clinical trials. We've seen in all the cardiovascular outcome trials, women are underrepresented. And I am guilty as charged because when we participated in the LEADER trial, we had 33 patients, only one of them was a woman. So, first of all, we need to appreciate that many physicians are underinformed about a woman's cardiovascular disease burden, and I've just put the figures over there so you can recognize yourself from there in the room. And here again, I've sort of given you the figures, whether you're looking at hypertension, diabetes, heart failure, hyperlipidemia, there are less women that go into these trials. Why does it matter? It matters because there might be a different presentation of the disease. We've already discussed about the anatomical differences, and then there may be this difference in the response to therapy as well, and therefore there needs to be equal representation of women when we're doing the trials. So how do we move forward then? What can we do in order to improve heart health in women and in women with diabetes? So first I'll touch upon some of the barriers for women to enroll in clinical trials, and the barriers may be associated with both the patients themselves and of course us as healthcare providers. So what are the barriers that are more unique to women? Well, we have trust issues. We don't trust everyone. And therefore, there's this fear of experimentation, you know, transportation, the convenience of coming into a clinical trial setup. Women make decisions a little bit more differently. We need more time to absorb and digest the information. And the decisions are not entirely our own because they are dictated by some of our family members. So the woman will come in and say, oh yeah, I think it's fine, but I need to discuss that with my spouse, maybe my children, and so on. And then there's the sex-based differences in risk tolerance as well. You know, under stress, women take fewer risks than men do. And then women usually perceive that it's a greater risk of harm from being in a clinical trial. So some of the provider barriers, so those was barriers on the side of the women. We as healthcare providers, of course, when they present with atypical symptoms, we're not aware that perhaps, you know, they could be having the disease. So there's issues with misdiagnosis and awareness. We tend to be subjective in our judgments as well. So, oh no, I'm not going to ask her because she'll probably say no. So you don't want to go into having that conversation. Then there's the administrative logistical, you know, burden. As soon as she says, well, you know, I have to drop the kids to school and I have to do this and to do that, how are you going to make those clinic appointments work? And of course, sometimes there's also problems with communication because you've got to do a lot more explanation than, I guess, to a man. So what are the strategies that we can actually do to improve this? Well, improve the awareness of cardiovascular sex-specific symptoms, and therefore have these targeted education campaigns. And this is, I guess, the beginning of things. Leveraging social media as well. So social media can be used in positive ways, not just talking about statins are not good for your health, but we can actually use it to our advantage. And then, of course, we have these very bold and emphatic statements from the various authorities. This is from the European Society of Cardiology, following the Lancet Women and Cardiovascular Disease Commission report that is going to be discussed, I think, in the next session as well. And what they've actually laid down is to try and make sure that we identify and remove these barriers that I've already alluded to for women to participate in clinical trials. There's got to be a greater investment in research that addresses women's health, supporting the awareness-raising initiatives, specific education activities for healthcare professionals, and to increase the number of women within the cardiology field. And I think Rashid Hospital is trying that. We've got Dr. Jwairia there, and she's got a nice mob behind her now. On the other side of the Atlantic, the same message was echoed by the American Heart Association president, Bob Harrington, and he had the same words, the same message in just different words. So the other thing is, and you can see I'm dressed in my nice bright red today, is the Go Red as part of the awareness initiative, just as you have pink for breast cancer, particularly to target women in their age bracket of 40 to 60. So just to kind of summarize, how do we mitigate the risk and improve outcomes in women with cardiovascular disease and women with diabetes, is first to make sure that we identify the disease appropriately, starting them and titrating appropriate guideline-directed medical therapy. So in women who have high cardiovascular disease risk should be offered the injectable GLP-1 receptor agonists. They should be given SGLT2 inhibitors as well, and not, think that they are more at higher risk of developing the side effects and therefore deny them of the benefits of these medications. We need to continue to engage women with lifestyle modifications, and of course, as I've mentioned, increase the representation of women in clinical trials. And with that, I'd just like to end with a note that heart disease is a now problem and later might really be too late. Thank you for your attention, and I look forward to your questions.